Welcome to Crazy Stupid Midlife with Danielle and Renee, your weekly dose of real talk, ridiculous laughs, and radical reinvention.
We're two midlife women ditching the old script and writing a brand new one, where hot flashes meet hot takes, ambition meets authenticity, and reinvention isn't just possible, it's inevitable.
Whether you're navigating career pivots, relationship shakeups, parenting teens, or just wondering if you're the only one who feels a little bit crazy, you're in the right place.
So pour the coffee or the wine and join us as we rebrand midlife, one honest, hilarious, and heartfelt episode at a time. This is part 2 of our conversation with Dr. Sara Mckinney, OB/GYN, and the truth teller about all things women's health.
If you thought part 1 was juicy, buckle up. In this half, we're talking about sex after 40, pelvic health, navigating hormone therapy, and the actual science behind those symptoms we've all been told to just deal with.
It's honest, it's empowering, and it's exactly the kind of midlife convo we wish we'd had years ago. Isn't that the truth?
Let's get back into it.
I have a question really quick, and this is backtracking a little bit. So we talked about hormone replacement therapy, progesterone, estrogen, testosterone. Something that I find amazing, that's been a game changer for me. So I'm on HRT, this little personal, but I'm on HRT, and I've been on since December. Life-changing for me. But I had an ablation years ago, and so it's just been wonderful. But I just recently had done the vaginal estrogen. Oh my God, life-changing again. Yeah. So I was on the ring, very expensive, by the way, again. Yes. Thank you for insurance is not covering anything for women. Yeah. But it was wonderful, but I think it was like a little uncomfortable. So then I switched to, I had my gynecologist switch me to the inserts, and they're amazing. Yeah. It's amazing. A game changer. Do you prescribe that?
Yeah, absolutely. And it's important to distinguish to patients that treatment of vulvovaginal symptoms, the dryness, the pain with intercourse, is quite different than, with local hormones, is quite different than systemic hormone therapy. Yeah. Different side effects, different risk profile. A lot of people really hesitate to use systemic hormone replacement therapy, unfortunately, because of, how things were interpreted in the past. Yeah. But local estrogen, it's quite different. Can some of it be systemically absorbed? Yes, but in very small amounts. And in general, the studies have shown that the amounts are less or in the same range as what our estrogen levels are in general post-menopause. Yeah. And there's different formulations. There's the tablets known as Vagifem. There's creams, Estrace. There's the ring. Which is great because you put it in and it sits there for 3 months. Yeah. But it is quite expensive. I've had patients tell me $300 to $400.
This ring is thick.
It's quite thick. I always tell people it's like a hair tie that you fold into a taco, but a very thick hair tie. Yeah. It's like 10 hair ties in one. Yeah. And then there's the suppositories called Imvexi.
I think that's the one I have.
And that's kind of cool because they have a small dose, which is smaller than the other ones. I think it's 4 milligrams. And then there's the 10 milligram, which is the more standard dose that you see in the other formulations. And it really just depends on what the woman's preference are. Some people like the cream because they can also apply it topically to the vulva and benefit from that. But then I have other women who say, it's so messy, I cannot do this.
Yeah, that's kind of how I was,
Yeah, so then we'll try something else and do something different. Yeah. But lots of multiple options. It helps prevent your recurrent urinary tract infections, pain with intercourse, sensitivity, burning, itching.
Just dryness in general. Because this is TMI. Sorry, listeners. But as you age, like when you're younger, there's more moisture. You have normal discharge, right? And as you get older, it's a desert down there. Like that just doesn't happen. Yeah. And then when I started using the estrogen, the inserts, I was like, oh, I feel like I'm young again because it's the feeling as it used to be.
The analogy I give people is like the vagina again is skin just like the rest of our body, and we forget that. And skin I always think of as like a brick wall. There's multiple brick layers, and when we're premenopause we have like 10 brick layers, and then as we enter perimenopause, menopause, we have like 2 to 3 layers of bricks. It's much more thin, it's more fragile, it's more at risk for trauma. And so when you give back estrogen to the local tissue, the tissue replenishes, it becomes more resilient, it is thicker, it has more blood supply, and those symptoms go away. But when you look at the images, it's really impressive, like when you see the stark difference.
Yeah. I just think that that's one of the, besides HRT, that is one of the things that's a game changer for women our age. It really is.
And I think it's when people will come to me with symptoms, they'll say, like, if they're saying, like, I'm postmenopause, I want to talk about hormones, and then they specify, I'm not having hot flashes, I'm having pain within, or like dryness or pain, but I don't want to go on hormone replacement therapy. And it's nice to let the patient know, like, you don't need hormone replacement therapy. We just need to treat the local tissue.
Yeah.
And there's, a much more reassuring side effect profile for patients in this regard.
Yeah.
And so...
And that helps also with recurring UTIs. I heard you mention that. Because I get UTIs very easily.
Yeah.
I always think it's because I have to hold it. As a teacher, I can't go until the bell rings.
Yeah.
But I have been known to get up to 3 or 4 a year, and they're really painful.
Yeah.
So is that because of low estrogen, or what's happening there?
It can be. Just because, again, all the vulvar tissue becomes kind of atrophied and thinner, and so it's more predisposed to trauma and bacteria, and so regular use of estrogen in the vulvovaginal area has been shown to decrease the risk of recurrent UTIs. And so, it's low risk, tremendous benefit.
That's great.
I would recommend it if you're having those kinds of symptoms.
Yeah.
Which is crazy that
I have a lot of friends that have UTIs too.
No one's ever mentioned that to you.
No one. I always just go on antibiotic for the 2 weeks, and then it comes back, and I think
did I kind of get upset the other day? I was like, why is no one giving you estrogen, vaginal estrogen?
Yeah. It sounds like you'd be a good candidate without knowing all of your
history. Yeah. Right. I know I'm always just, try this.
What about thyroid issues? Is that something that women should be adding to their checklist when they see doctors in midlife? Like, even if they didn't have a thyroid issue before, should they be checking thyroid? Is it common to develop thyroid issues in perimenopause, and how does it affect, like, perimenopause in general?
Yeah, that's a great question. We most of the time people are getting screened for the first time around the age of 35, potentially earlier if you have a strong family history or risk factors. And then I think most of the time the screening is usually, I want to say, every 3 to 5 years. Sooner, again, if you have a strong family history. I tend to screen people who have irregular cycles because that can be a cause of irregular cycles. So it's not unreasonable, if somebody's coming to me with, change in their cycles or change in symptoms, racing heart, constipation, diarrhea, hot flashes, just get a thyroid. Make sure it's not that, because it'd be such an easy thing.
Fix, yeah.
Exactly. And it's low stakes, it's easy to do, and it's part of routine health screening anyways. So getting a thyroid is a very easy and straightforward thing to do.
Because they can have some symptoms related to that.
Yeah.
So I have a question, and this is just random. When you do a thyroid panel, do you ever check the reverse T3, and why don't you if you don't?
That's a great question. In general, most people will just get a thyroid stimulating hormone, just because that in itself, if it's in normal range, is generally reassuring. Now, if it's not, getting additional hormones can help you interpret it, because you may have a very elevated or a lower TSH, but depending on what the T3, T4 is, will let you know, like, is this true hyperthyroidism or true hypothyroidism, or is it subclinical, meaning, the data suggests it, but the patient may not actually be symptomatic. So it just helps interpret the patient's symptoms and the actual diagnosis.
Okay.
But sometimes when it gets a little bit too complex, though, I will defer to my endocrinologist.
Okay. Because, but even endocrinologists, a lot of them don't do the reverse T3. And I find that a lot of people are on high levels of levothyroxine, and it's actually not even hitting the problem, because it's a conversion problem, I think, between like I don't know, but it's like the T3 and T4. There's no conversion. So it's not even affecting the problem. Yeah. So anyway, I just thought maybe you knew some information about the reverse T3.
As a general gynecologist, I know some And then when it gets complex or
Yeah.
beyond,
Yeah.
I generally would defer to my endocrinologist or primary care provider.
That's why we have the specialty. Okay. Let's see. What did you say here? What should midlife women ask for during their annual OB/GYN visit?
That's a great question. I always encourage people to come with, particular questions or concerns. I always start my visit with, my understanding is you're here for an annual exam. Are there other things you would like addressed at this visit? Mm-hmm. And sometimes people will ask, bring something up that is going to take the whole time. And I will be clear and I'll say, it sounds like this is more pressing. Do you mind if we focus just on this topic and not necessarily do the annual exam? Mm-hmm. And most of the time people say, yes, absolutely. This is way more important to me. Because when you think about an annual exam, a lot of what we're doing is, one, reviewing all your medical history, because who knows when the last time you saw a healthcare provider was. And if you bring up something that should be addressed, then I want to be able to either put you in the right direction or address it myself. But, other things we're doing is reviewing like your obstetrical history, and if you want more children in the future and what that means based on your age. What has been your gynecological history? When was your last pap smear? Are you due for one? Do you have a history of abnormals? What are your menstrual cycles like? Are they heavy? Are they long? Should we address that? What kind of preventative care have you recently engaged in? Are you due for mammograms, colonoscopies, a bone mineral density scan? And so a lot of my questions are just making sure your routine health maintenance is up to date. But some people are really linked in the system. They're doing that they have a primary care doctor, they're doing a lot of those things. And so I may be prepping for the patient. I'm like, they don't need a pap smear. They just had a mammogram. And then if they come to me and they're like, I've been really sad lately. Feeling really anxious. Sometimes I'll say, your stuff's really up to date. Do you want to just focus on this topic?
Yeah.
And so I think it's important for people to come in knowing sometimes an annual exam is just going to be an annual exam, meaning going over health maintenance, making sure it's up to date. And sometimes it doesn't allow for additional problems. Sometimes they can be incorporated in the visit, but really come in with an agenda so that you can advocate for your best self and prioritize what you want more. Maybe your PAP's up to date and we don't need to do a pelvic exam, and we can really just talk about a new birth control option, or because of heavy periods that you've been having, and focus on that.
What is the protocol now is it every 4 years for the pap smear? I can't remember.
Yeah, depends. Under the age of 30, we're just doing the pap smear. And what the pap smear is, it's a test to collect cells off of the cervix. And then a pathologist looks under a microscope and looks at the cells. And if the cells look normal, they say normal. But what we also do now is do HPV screening. So there's cytology of the cells and HPV screening. Under the age of 30, we generally just do cytology cells. If they're normal, repeat in 3 years. Over the age of 30, we do cytology, the cells, plus HPV screening for high-risk strains of HPV. If both are negative with a normal past history of pap smears, you can repeat it in 5 years. Mm. We've now expanded how frequently we're doing the pap smears because the HPV testing, when they've studied tens of thousands of women, is really good at predicting who is the higher risk for developing precancerous cells of the cervix and ultimately cancer. Mm. And that is always adjusting. People will come in and like, no, I do a pap smear every year. I'm like, well, we don't anymore. The guidelines have adjusted. And this is why we can feel confident and safe waiting another 3 years or so for you.
Okay.
Yeah.
And then do you think mammograms are important as well every year?
Yes. So the American College of OB/GYNs recommends mammograms starting at the age of 40. Other organizations have different starting points, like the American Cancer Association and the United States Preventative Task Health. I always forget the acronym.
Yeah, it's long.
Yeah. They start around, I think, 45 and 50. I think it's a shared decision with the patient, but in general, the organization that I follow and that I trust has recommended the age of 40, potentially earlier in women who have a strong family history or a first-degree relative who had a breast cancer earlier in life, or if they have screen positive for a genetic mutation that would further increase their risk of breast cancer.
Like a BRCA.
Exactly. And so some of what the healthcare annual exam is, it's also reviewing your family history for genetically inherited, cancers that can be genetically inherited: breast cancer, ovarian cancer, colon cancer, and uterine cancer. And so if somebody's screening positive and they have a mother, a sister, an aunt, and they have multiple first and second degree relatives, that's a patient who I'm going to recommend get genetic counseling and potentially testing, because they may benefit from a different screening guideline than the general population.
Yeah, that's good. It's always good to know, because I don't think, I'm a nurse practitioner and I don't even know the guidelines and when I'm supposed to go and follow up. But I hear that mammograms have a lot of radiation, and so there's conflicting information out there as if you should be doing it every year. I don't know. Sometimes I don't know. I'm sure that's a worry with some people. They might bring that up.
Yeah, it definitely is, and I think that's why we've tried to find an age that we think is most appropriate, that balances those risks. The risk of eventually developing breast cancer, just because age being the biggest risk factor, but then also the risk from radiation exposure,
right.
which is why we don't start before the age of 40, unless we know you're high risk.
Yeah.
The other things that I've started incorporating into my practice as well is different calculators or models that can be used to determine if somebody is moderate or high risk for developing a breast cancer.
What is the calculator you use?
So there's a few calculators. There's the Gale model, and then there's the Tyrer-Cuzick model. They're which can, on average, 1 in 8 women is going to get a breast cancer. Yeah. That's about a 12% risk, right?
Wow.
And the risk, we put them in different buckets based on family history, personal risk factors. And so these calculators give you your risk, and you may use the calculator and get like a 22% risk. That's substantially higher than the general population.
So then what do we do?
In those populations, we screen them differently. We may incorporate breast MRIs, alternating every 6 months. There's a celebrity recently,
Olivia Munn.
Yeah,
I went on and did the tire.
Yeah,
she so that's how she. What is it called exactly?
I know I always mess up the name. Tyrer-Cuzick mod.
Yes,
calculator.
I think you're right. Yeah.
So that's how she found out.
She was actually screened normally or something, and they didn't find it.
She had just had a mammogram that was cleared, and then her OBGYN did the calculator on her and said, "You're a really high risk for breast cancer. I'm going to order you an MRI," and it was detected on the MRI several months later.
Yeah.
Wow. And so
that's my other question is like, okay, so we're going to do a mammogram every year, but it's not getting it all, and then we're exposing ourselves to all this radiation,
and they're super painful.
So why can't we just get MRIs?
That's a great question.
I asked my gynecologist that.
Yeah.
I told her, because I was having to get mammos all the time, and I said, can I just get some MRIs? Like, I don't want this exposure.
Is it cost? Does it insurance won't cover it?
Correct. It's they're not all institutions have MRI, so it's a limited resource, and they are quite expensive. Insurance does not cover them. So then you have to decide who in the population will benefit most from this limited resource, which is a lot.
Can you opt to pay for it yourself?
You could, but I can imagine it would be thousands of dollars.
Wow.
Yeah.
Well, now they have, what do you think about, is it Prenova or these other, where they can scan your whole body? And
I saw that too.
What do you think about these things? I don't know anything about them. But I see them all over now.
I think it's really interesting. I've also thought about it too. I think it depends on a few things. One, is it evidence-based? Have we ever studied people and realized we are picking up more things and it is improving mortality and morbidity of patients? And who's reading the imaging?
Yeah.
Because I personally would want my brain MRI read by a radiologist who specializes in neurology, not a general radiologist, right? And so
that makes sense.
You have to wonder, like, who's reading the imaging, and
how quickly is it being...
Because honestly, it's your whole body, so there's so many systems there. So a radiologist wouldn't know, like you just said, neurology versus something else.
They may have had gone through, I don't know what their training is like.
That's a good point.
Probably been exposed to it, but I think if I had something going on specifically, like I want that body part read by the person who has spent the most time, who's doing those images all day long.
Yeah, I can't imagine that's happening.
I don't think so either.
Yeah, because that would be a lot.
Yeah.
Very expensive.
Yeah.
What about you mentioned the bone scan. Is it called DEXA scan? Is that what it's called?
Yeah.
Is that something that most women can ask for at their like midlife checkup, or is it something that you have to have a certain pre-existing condition to get?
So
And the radiation on that.
Yeah, so the DEXA score is usually done at the age of 65 for most women. But what you can do is, again, there's another calculator you can use to determine should some people be doing it sooner rather than the standard age, and that's called the FRAX calculator.
FRAX. We should put those on our notes, the FRAX and the
Tyrer-Cuzick and the Gale model.
Yeah.
The Tyrer-Cuzick is my understanding is it's geared better for people who have a strong family history because it takes more family history into account.
Yes, it does. Mm-hmm.
The Gale model, I believe, incorporates a little bit more of personal history, like have you had a prior biopsy? What was the result of the biopsy? When was your first child? When was your first period? There's a couple of other models that also incorporate prior genetic testing. So like if you're a BRCA carrier or some other genetic gene. But the FRAX score is nice because it takes into account, like, have you been on oral steroids? Do you have a family history of somebody with a bone fracture? Do you smoke? What's your BMI? What's your race? Because all those things are risk factors. And I believe if like your risk is, I have a template that I use, but if it's like above 11% or something, then you're considered higher risk, and then you should be getting a DEXA scan before the age of 65.
But also, too, with Ozempic, I mean, there's a lot of muscle mass that's being lost when they're on that, and then bone loss. So I think osteopenia is probably going to be a huge thing in the near future. So they need to adjust that.
Yeah.
That to if you're on that.
Are you taking Ozempic?
Yeah, that's a great point.
GLP-1.
But I think that also brings to light like why it's important to make sure you're getting prescribed by somebody who like knows all those things. Like me, I didn't know that. You're informing me for the very first time.
Yeah.
And so like I'm not the right person to be prescribing that because I just don't know the ins and outs of that medication.
But if you see someone in their history and they're on a GLP-1 and have been on one for a long time, they need to make sure they're doing weight-bearing exercises, and if they're not, they're going to their bones are going to brittle away.
Yeah, that's a really valid point. Those are
so
things
they're
like,
going to need a DEXA.
Yeah.
But so is DEXA radiation high like a mammogram too? Do you know?
That's a great question. I really don't know the specifics about that in all honesty, because most of the time I'm not ordering it as a gynecologist. I can. Most of the time by then people are getting it ordered by their primary care doctor.
Okay.
But they don't occur very frequently. They're not something you're doing every year.
Yeah.
You get a clear or you get a osteopenia follow up in 1 to 2 years or so different frequency.
Okay. Well, thank you for all of that information. Yeah. Do we have more questions?
I know we have some rapid fire.
Is there anything that we didn't touch on that you wanted to talk about, or something important, or something that we're missing?
Oh, I have one good thing.
Okay.
Because the question I get a lot is people requesting hormone testing.
Oh yes, this is such a good one.
That is a good one.
Yes.
And so I get this a lot where people want their hormones tested to know if they're perimenopause or postmenopause or the timing. And unfortunately, the hormones are not very helpful, or they can be really difficult to interpret. And so I will caution people about that. In general, I don't recommend checking the hormones, but can I? Absolutely. I just have to explain to people, like, these are the possible things that could happen, and I just want you to understand that. And then the patient can decide. But essentially, when you're perimenopause, your hormones can be all over the place from hour to hour. So I may check your hormones at 10 a.m. and they could be completely different at 11 a.m.
Hence the rage.
It's so wonderful being a woman.
Literally, you can literally look at this gram, like anybody who's in their 20s, 30s, they have this like beautiful double, like nice graph. And then perimenopause, it's like all over the place.
It's like shark fins.
Yeah. And so I caution people because it just may be difficult to interpret. It doesn't give us any idea of when you're going to go into menopause.
Yeah.
It doesn't help with timing. It also isn't necessary if you're not feeling well and you want HRT. If you want it and you have symptoms and you're safe, I'm going to give it to you.
Yeah.
I'm also going to adjust it based on your symptoms. I'm not going to go off the numbers because, one, it would also be unkind of me to say the numbers are normal, the symptoms don't exist.
This is what everyone gets, though.
Yeah.
So many people, I've checked my hormones, they're fine. No, that doesn't have anything to do with how you're feeling. None.
So I always tell people that, like, I could get them and they're totally normal. how will it make you feel for me to say, looks good,
Oh, yeah.
I'll see you in a year? You probably wouldn't feel good.
99% of the people get that.
Yeah, and so I just tell people, like, I believe you. I know you're having symptoms.
Yeah.
I don't need the hormones to justify it. And they may actually do the opposite and make you feel even dismissed.
Yeah, like you're in your head with all your symptoms and it's just not
Yeah.
real.
So true.
So many reasons as to why it's generally not helpful.
The hormone testing.
And even
Okay.
like right before your period, your hormones are different as opposed to during your period and right after.
Every day of the cycle, the hormones are different.
Yeah.
And I also sometimes will have patients come to me where, you know, I just got my hormones tested. Can you interpret the labs for me? And then when I ask them, like, but you're on a birth control pill, you shouldn't be getting.
Right.
Yeah, I was
Oh
like,
my
who
gosh.
ordered them for you? And then I feel bad because then the patient feels silly. I'm like, this was the wrong, like, you shouldn't have actually had hormones tested because they're being falsely manipulated by the
Yeah.
hormones you're currently on, potentially.
So what if you're on HRT and you want to make sure that your one isn't too high?
yeah.
Is that
Symptoms, right?
yeah, like, well, let's say like you're on like a low dose estrogen, or maybe they put you on like a middle of the range, and you get tested and your estrogen is really high. Would that be something that would come up or no?
In general, no, you don't need to with commercially available hormones.
Okay, because it's such a low dose, right?
Correct.
Yeah.
It's, you know, most people's hormone levels post-menopause are going to be like 10 to 20 picograms. When you're on HRT, it's generally going to be under 100, you know, and so it's usually not going up that much higher. And oftentimes people are going to start having symptoms, like they're going to start bleeding, they're going to have irregular other symptoms where that may prompt you to get a hormone level to make sure they're really not super therapeutic, but generally not needed and not routinely done.
And just to clarify, hormone replacement therapy, bioidentical, so it's made kind of you, right? Kind of the same hormones that we produce ourselves.
They're structurally, their molecular structure is identical to what we produce.
Okay.
They're made from plant
Plants,
precursors, and then they're structurally identical to what we make.
Okay. And birth control, not
Synthetic, right?
yeah,
Synthetic.
synthetic, so it is synthetic. That's a higher dose.
Correct.
More potent, right?
More potent, longer half-life.
Okay.
And so it's different.
Even if you're on a low dose birth control pill, same.
Correct.
Okay.
Why would you introduce an IUD to a midlifer, perimenopauser?
That's a great question. IUDs are essentially little T-shaped devices that get placed into the uterus in the office, and they release a small amount of progestin every day, levonorgestrel, and
So that's just progesterone.
just the progesterone. It
Nothing
is
else.
synthetic. It is not bioidentical. And there are different, so some people use it off-label as their progestin. So whenever you put somebody on hormone replacement therapy, it's two hormones usually, estrogen plus progesterone. The estrogen is what treats the symptoms. The progesterone is what protects the uterus, because essentially the way I like to think about it is the estrogen is the fertilizer. It makes the grass grow. But if the grass grows too much, it can cause problems. And so the progesterone is the lawnmower. It trims the grass, it keeps it level, so you're not having irregular bleeding, breakthrough bleeding, periods, or inappropriate growth of that endometrial lining that increases your risk of hyperplasia, precancerous cells, or even cancer. It prevents that. And so, but you have to take a progestin pill every day. And so some people have trouble doing that, understandably. What the IUD does is it gets placed, it lasts 5 years, and it releases a small amount of progestin that is more of a local effect, and it's keeping the lining really thin. And so it's being used for the same reason. It's just, you know, kind of like the ring you put in the vagina. You leave it for 3 months and you can forget about it. There's pros and cons to it.
I just had another question.
But it also like helps prevent pregnancy, right?
Yeah. So
How does that part work?
yeah.
Just out of curiosity.
Absolutely. So it essentially makes the lining so thin that there isn't a supportive environment for an egg to stick onto. And so 20% of women at the end of 1 year will no longer have periods. 40% of women at the end of 3 years no longer have periods. So it makes periods much lighter or absent. It also increases the mucus in the endocervical canal, which is the canal in the cervix that leads from vagina into uterus. And so it's harder for sperm to go through. So it has a couple of benefits.
But the copper one is another option, but that one's non-hormonal, correct?
It's non-hormonal. It releases a small amount of copper. It lasts 12 years now. And
Wow.
it, the way it works is it creates a hostile environment so that sperm can't survive.
Okay.
Yeah. But 20% of women may have heavier or more painful periods. So I always caution people if that they already have a history of that, it may not be the best option. But some people don't do well on hormones, and that makes the most sense for them.
Okay.
Okay, I remembered. Sorry. I had to write it down, otherwise I can't remember anything. So pellets, this is my question. What do you think about pellets, and what's the difference, and why would someone do the pellets? And then why is progesterone so great for my sleep?
Pellets are interesting. So granted, I have not tremendous experience with pellets. I don't prescribe them as a general OBGYN. And essentially, pellets, from my understanding, are bioidentical hormones that have been compounded, meaning they are not FDA approved. They have not been studied in any of the big clinical trials. So we just don't have a lot of safety or efficacy data on them. Does that mean they're bad or wrong? Not necessarily. We just can't tell you definitively the way we can with some of the other formulations that are currently available. So in general, they're compounded bioidentical pellets are not recommended by a lot of OBGYNs for that very specific reason. And ideally in time we'll have more information, but
they're also expensive, and why not just get a patch that's covered by your insurance and progesterone or an IUD, whatever it is.
Yeah.
And it's covered by insurance, number one,
Yeah.
and then it's FDA approved.
Yeah, and your OBGYN can then confidently say, there was this study that studied 90,000 women. It was lower risk for this, previously thought complication. I can't say that about pellets. I don't know a lot about them. They've just not been well studied. And I unfortunately do see patients who come in and they're on pellets, and then the pellets are stuck in your body for 3 to 6 months.
You're right.
And I will check hormone levels in those patients because they're in their 60s, 70s, and they're having monthly periods. And I'm scared
Right.
because I'm like, I don't know what your breast cancer risk is. I don't know what your risk of endometrial cancer is. I don't know what your risk of cardiovascular disease or blood clot, because their levels could be in the 200-300s, which is substantially higher than it should be, and what's done typically with commercially available hormone replacement therapy. So
this just makes it so sad, because what happened with that study is they made everyone fear, so all the practitioners weren't offering it.
Yeah.
So then it's like the black market, you know, all these women are going, give me some help, give me some help. So they went and they got pellets.
Yes.
Because pellets came on the market, and you can go spend thousands and thousands of dollars, and then you get some relief. I mean, I'm assuming they would give you relief because a lot of people did it.
Yeah.
But now it's like, now we have practitioners that are open to prescribing HRT and becoming more and more aware of this is a good option for these women so they don't have to suffer. So if you're on pellets, go see your OB. I mean, then you can get it covered by insurance, and it's FDA approved, it's safe, and have that conversation.
Yeah.
Make sure that you're safe with what you're actually doing. Just like you said, someone in their 70s on a pellet,
Having a period. That's like my worst nightmare.
Yeah. And again, I think it comes down to, like, if you encounter a provider who's not making you feel seen and who's like not giving you a explanation that makes sense, go see somebody else.
Move on.
Move on.
Yeah.
That's not the right fit for you. Like, you have to advocate for yourself, That's not, like, I think my favorite part about medicine is, like, if I wasn't a healthcare provider, I'd be a teacher, because that's what I love to do. I love putting up photos, diagrams, doing the calculator with the patient in front of me, because I can say, like, and then it makes sense to them.
Yeah.
It's kind of like when I don't have children, but I can imagine when you explain to a child why we're doing something a certain way or something, and they can understand your rationale. It might be easier to accept, some kind of news versus no, because I said so. Just, and I don't want to treat my patients like that. I want them to understand my thought process and why I think it's safe and why I think it's okay, not okay. I think patients really appreciate it. At least that's what I've noticed. And so I just move on, like you said. Go to somebody who's going to make you feel seen.
I mean,
or at least explain.
At the end of the day, we're paying for our health care. Right. Make sure you're getting your money's worth.
Yeah.
Make sure that you're having connection. You feel seen and heard, and they're providing good care for you.
Absolutely.
My other question was, what did I say? progesterone.
Oh yeah.
Why
yeah.
does
Why does
progesterone
it
make us sleep well?
Yeah.
You know, that's a really interesting too. I definitely have patients who will ask, I want a higher level of progesterone. I feel better on it. I don't know the exact reason. When I looked at one of the studies recently, subjectively, people report better sleep quality.
Yeah.
Objectively, the evidence is a little bit more mixed. It's not as strong. And so, it's not very clear. Is it wrong to be on a higher dose of a progestin? I think it just depends on the individual.
Yeah, I would agree, because I've tried 100 milligrams and I've tried 200, and 200 is a lot. Like, oh, don't get me wrong, I'm sleeping like a baby, but I get little, like, it kind of can depress you a little too much.
Yeah.
So I think the 100 is just perfect for me.
Yeah, and that's generally my recommendation. And I will let people know, like, here's the pros and cons. Here's what could theoretically occur as a result. Do you feel comfortable with this?
Yeah, and I always tell my patients as well, it's trial and error. Every single body is different. We don't know how you're going to react. So if you're open to it and it's safe, let's try it. And then things need to be tweaked.
Yeah.
But at least have the conversation, because I think it's so important for women to have that conversation. Is this right for me? Can I feel better? Yes, maybe. Let's try it.
Yeah. I always tell people, like, you don't have to make a decision today.
Yeah.
You're going to see my note, and it's going to be done at the end of the day. It's going to summarize all the things we discussed. Go look into it.
Yeah.
And then come back, and we can either do another telehealth and talk about it, or you can decide and say, I do want to start this one, Dr. McKinney.
Yeah.
Great. There's no rush.
Yeah. Because they can just email you and say, hey, we just had a...
Yeah. It gives them time to think about it.
Yeah.
Because it is a big decision.
It's a big decision.
If you're deciding to go on HRT, especially if you don't take, like, a lot of people don't take anything at all. So starting HRT is, like, a little daunting, because they're like, well, I'm not taking anything, maybe just vitamins.
Yeah.
So going on something like that requires, to take daily or to change the patch, it's a commitment. So it is a big decision.
It is. You're right. Mm-hmm. And a lot of people who was this? I don't remember who it was the other day. She said she was on HRT and she decided not to take it anymore. And she goes, my mom is fine. I just think she got through it just fine. I can do it without it. And I felt like, oh gosh, poor thing. Like, what? You don't have to suffer, because it's that mentality of the scared. Everyone's
still in
scared.
people's mind.
Well, I think we've been socialized as women to
Yeah.
feel that way about so many things. I'll just tough it out.
Yeah.
Well, that's what I was going to say. I think a lot of women feel like they're weak.
Yeah.
If they decide to go that route, which is a shame.
Yeah.
Because, you don't have to feel horrible. There's no reason to feel that way. And it's no way to live. We talked about that in one of our episodes. There's no reason to feel terrible in midlife. I mean, midlife can be great. There's a lot of freedom you get in no longer having a period.
Wisdom.
I mean, I'm not there yet, but I'm hoping soon. But I've heard that. So I traveled recently with my friend to England, and she was there with her 80-year-old aunt and uncle. And we were talking about the podcast, and she is so healthy. It was crazy. She was walking like 25,000 steps a day. She was keeping up with us, and I was like, oh my God, you're like amazing. Like, you were my hero. How do you have so much energy? You're 80. This is insane. Like 30 years older than me. And she's like, you know what? My 50s were my best years. And she said, if I could say anything, and I don't know if she went on HRT, honestly, because that was 30 years ago. It was probably a time when they weren't doing it. But she said...
they were before they didn't.
Yeah, maybe. She said what she did to get through it was she tried to have a positive mindset. And I could tell she was one of those people that just had a positive mindset, at least tried to. And she said she exercised like crazy. Mm-hmm. She said she was probably averaging like 3 times a day doing some sort of exercise.
Yeah, but that is a lot.
I know, it's a lot. But what I'm saying is, like, that to me, like, I was just like, wow, we could have a good 50 years.
Yeah.
I mean, that decade can be great. And she said that she felt so much better after she stopped having a period, and things just got progressively better. And I think sometimes it's hard to see that light.
I know, but isn't it sad, though, that, like, we have to wait till we're 50? So what, our whole 40s is just a loss of feeling horrible?
Yeah.
That's so sad.
Well, I feel like it's I think that's why I love reading like so many different memoirs and understanding what
I'm
people.
so excited now to read the Brooke Shields one because that's been on my list.
I love, and then I watched Pretty Baby after, and it was so good. It was so
Pretty Baby.
That's her documentary.
Oh, okay.
It's a two-part. It's so good.
Well, I love Brooke Shields. I like grew up on her.
I didn't know her very well. I knew her a little bit, and then I read the book, and then I was like, I have to watch her documentary, and it was so good. I mean, she's just like, I thought it was beautiful because you see what she's like before, like pre 30 years old, and like all the things she's been through and how naive she was, and like, and then she goes into her 30s, 40s, 50s, and she is just like this transformed woman. And I feel like so much of our like 20s and 30s are like chaotic and you don't know who you are. And then I'm looking forward to 40s and 50s because everyone, like at least most of the women's experience I'm hearing is like, you finally know who you are. You're less concerned with impressing people. You have a voice.
Yeah,
you know,
that's true.
And so I think that sounds so wonderful. And like that makes me feel more empowered about, you know, the biological changes I might be, you know, seeing very soon. And, you know, I think reflecting on your friend, I think I have to constantly remind myself I have more control over my happiness than I realize.
Yeah.
And
Such a good quote.
I like literally have to remind myself, like, if I'm not happy, okay, what can I do? Maybe what I have to do is going to be uncomfortable and difficult, but if it's going to result in happiness, it's probably worth it. So like, even when I left Boston, it was devastating for me, but I just knew there's something that I want and I think it's going to be worth it. And it was like so hard, but like all the things that were troubling my life at that time are so much better now. And it just I just had to go through that discomfort, and nothing worthwhile is easy. Like nothing.
The truth.
You have to go through discomfort to come out a better version of yourself. And I feel like that's how life has been in so many experiences when I reflect back. And I love that about memoirs because you see like, dang, Demi Moore went through that.
Oh, I've read her book.
I loved her book. Minka Kelly went through that. Brittany,
I have to read Minka Kelly's.
Really,
yes,
I'm like such a memoir person. Paris Hilton is one of my favorite memoirs.
Wow.
Like, I just like, it reminds you.
I know, I'm all...
I know.
Because I'm going on a trip. I'm going to put these on my Kindle.
I'm going to put all these on my...
Viola Davis's is also like, ooh, I could only do it chapter by chapter. Like, I had to take breaks because it's emotionally so hard.
Wow.
But I think it reminds you, like, we're not alone in this journey. And I think human connection is so important. Yeah. And the evidence shows, like, you live longer, you live happier lives when you are connecting with people.
For sure.
And sharing your experiences. And so if I could encourage people to do anything, it's like, find your safe people, find your circle, and tell them what you're feeling, what you're experiencing, regardless of how embarrassing or taboo it may feel, because you're going to realize you're not alone.
Yeah.
And they're going to help you brainstorm and come up with an ideas, or even just be your cheerleader. Like, just do it.
And your vulnerability will lead to oftentimes them being vulnerable back.
Yeah.
And then there's this like deep connection that's happening because you opened up about something and then they were like, okay, now it's safe for me to do it too.
Those have been my favorite evolutions with some of my friends. It's like I can tell for the first time they're telling me things that they have not traditionally shared with me. And I'm like, okay, it's been 15 years, but maybe it's because I just like word vomited my life so many times that they finally realize like, I'm a safe place.
Yeah.
And that feels really wonderful.
Yeah.
And like,
it
so
definitely does.
Hold on to those people. They will make you feel safe, and they will be somewhere to lean and like onto when you're going to go through something that is potentially going to be incredibly uncomfortable.
Well, that's why we started the podcast, because we want to share our experiences so that people don't feel alone, because not everyone has a friend who they can feel comfortable with talking about it. I mean, we even just like, we don't know you very well, and look at, we're telling you all of our, you know, problems and symptoms and issues. But again, it's because we wanted this to be raw. We want people to know they're not alone. Yeah. And everyone is experiencing something. And there's so much growth happening in your 40s. Yeah. That it's almost like so much growing pains, like a different type of growing pain.
It's like a second coming of age.
Yeah.
Do you know what I mean?
Yeah.
Like when you're young and you hit puberty, you come of age, right? You lose your innocence and you realize that, you know, so many things.
Right.
And then I feel like this is an opportunity for a second coming of age. Yeah. In a really different way, because you're older and you have more wisdom and you have more experience and you've gone through so many more things. So I also like looking at it with that, mindset, because I do think mindset is ultimately really important.
Yeah.
Of course, so is, treatment and hormone replacement therapy, but I'm really big too on the lifestyle medicine, and I think mindset can definitely affect you in a positive way.
100%. I think it's so huge. And like, don't get me wrong, I give myself space to like grieve or cry. Like, I love to cry. And then
So does Renee.
Obsessed
She's
with
a
crying.
crier.
We had this joke in residency that 17 of the 24 residents had seen me cry before the end of intern year. And I'm like,
so awesome.
That's my reputation. Whatever.
Great.
I think vulnerability.
It's
That's
therapy.
wonderful,
Yeah.
though.
I think Brene Brown would say
Yeah.
it's a strength.
Yes.
But I just like, I give myself space, I'll grieve, and then I'm like, okay, girl, what's the plan? Let's go. Like, you have to, like, I'm responsible. Nobody else is going to fix something for me. So figure something out. Come up with a game plan. And even if it doesn't work out, the idea that I have a game plan and something to look forward to, that in itself is motivating and gives me, like, the courage to be like, okay, well, this is the best that I can do today. And I one time looked so sad in my office. One time I had something happen in the hospital. I was having a really down day, and my medical assistant came in and she's like, Dr. McKinney, is everything okay? And she's like 10 years younger than me. And and I'm like, I just, this happened, blah, blah, blah. She's like, are you doing the best you can? And I was like, it like brings me to tears almost. And I was like, always. And she's like, that's all that matters.
Yeah.
And I think you can apply that to anything.
Yeah.
Your job, your family, your kids, like everything, right? If you're doing the best that you can, you're being a genuinely kind person, and you're advocating for yourself in ways that are like meaningful and kind, then that's literally all you can do as a human being.
Yeah.
Right.
It's amazing that she had that wisdom.
I kept the sticky and she wrote it and she's like, you're doing the best that you can. And then I've kept it all this time because I have to remind myself that. Are you doing the best you can? Always.
Well, it's hard. The pressure to be a provider these days is there's so much information out there that to know it all and to be able to regurgitate it to each patient and to mold it to each person.
Yeah.
It's a lot.
Yeah.
And sometimes I get
a lot of pressure.
I get decision fatigue and trying to make the right decision for every patient. And then I roll over in my head, did I write down every single thing that I was supposed to do?
Yeah.
Like, because you're seeing so many patients too. And like, it's a lot.
Yeah.
And it's a lot of stress. And being a provider is difficult sometimes, but if you are just generally trying to do the best you can for every single person, that's all you can do.
Yeah. I think it's definitely high stakes. It's a lot of multitasking. It's a lot of like working with different personalities.
Yeah.
And I think the way I've currently am trying to work through it when I'm having hard days is, are you being the kindest person you can be? And are you proud of yourself at the end of the day? And if I can say yes to both those questions, then I'm generally like, okay, that's the best that I can do.
Yeah. And we would love providers like that, right? That's what we want. Someone who sees us and cares and has an open heart. So
And oftentimes people just really ultimately want to feel heard.
Yeah.
Like bottom line in life, not just in,
in everything.
If you feel heard and understood, it's like, it feels so good.
Yeah.
You feel seen and you're like, okay, it's almost like you can get past it now.
Even the visits where I'm just like, I'm really sorry you're going through that. Just that I can see is like a game changer for
like
people.
A huge like,
okay,
right?
Somebody acknowledges that I'm not in my head.
Yeah,
that this isn't
losing my
make up.
mind.
Yeah.
Well, you have to understand, and I think I'm realizing this more and more when I talk to you too, but it's not just us going through this. We have a husband, we do, but we have people around us that are counting on us and watching us either fall apart or not know what to do, or so then the relationship suffers sometimes with the kids or yourself or your spouse.
And then you withdraw.
Yeah. And then you go see a practitioner and you're like, I am not normal. Like, something is happening to me.
Yeah.
Please help me. Like, what's going on? And then they're saying, no, you're fine. Your hormones are normal. Absolutely not. Like,
or this is a phase.
Yeah. And your husband's like, I can see you're struggling. I can't help you. I don't know how to help you. No one knows what's going on, you know? So like most people, women in this time of their life, they're just struggling. And there's a lot of people around them that are affected.
Yeah. That are struggling too in their own way.
Yeah.
We've thought about having our husbands on to hear, their perspective.
Yeah.
I told my husband that the other day. He's like, oh.
That's exactly what mine said. He's like, I don't know if I want to do that.
Yeah, because
I think they're afraid of
hard.
being honest.
My husband said the other day, I don't know, sometimes when you wake up, I don't know which person I'm going to get.
Oh my
I'm like,
gosh.
yeah, it sucks. I don't know either. I don't know either.
I'm just as surprised as you are with these showing up today.
I think it's good for men to understand what we're going through, though, because I literally had a conversation with one of my male friends recently, and we were talking about fertility rates because his cousin is undergoing fertility rates. And I was like, oh, yeah, how did it go for her? He's like, I don't know. And I was like, well, yeah, her percentage this month is 15%. And he's like, wait, what? And he didn't understand the numbers. And I was like, well, you said she's this age. And so this, and he's like, wait, what? And I was just like so taken aback that he did. And then we started delving more into this and how like STIs are transmitted, what fertility rates are every month, what egg freezing. And he just had no clue.
Idea.
And I was like, oh. I was like,
because they don't really learn about that. There's a very short sexual education that happens in, what is it, middle school?
I mean,
but literally every single page, my daughter came home and I had to initial for her to be allowed to learn that content. And then it was like over a week?
Yeah, I don't remember it.
Well, when I remember it was taught my second year of high school by our gym teacher, who I was like, he probably doesn't want to teach this.
Right.
I don't want to.
It's so awkward.
It's so awkward. It wasn't,
Oh, health class. Was it health class?
Mm-hmm.
Well, and also the hormonal changes in men. I know that they have them, right? I'm not trying to, what is the word I'm looking
Minimize.
for? Dismiss them.
Yeah.
But like, I was seeing this Instagram post the other day, and I sent it. Did I send it to you? I sent it to a couple people. It was really funny. So men hormones, right? And the guy's lifting, like, he's bicep curling weights. And there's a girl next to him, and she's got smaller weights, and it said women's hormones. And she lifts, and then she runs around him, and then she jumps up and down, and then she collapses. And then she gets up, and then she gets really mad, and then she runs, and then she collapses. And like at least 4 times.
Doesn't she say like F you or something to him too? Because that's like her hormones are going like, and then she's loving it. Like it's just all over the place.
And she's running and smiling. And then the best part is how many times she collapses. And at the end, she collapses face down. And I'm like, exactly. And the whole time, the man is still lifting the weights.
Doing the same thing. He's just like straight
and not reacting. It was so funny, but also so accurate.
Gosh. We have it great. Okay, so what is the one thing our listeners should do this week to feel more empowered about their health or midlife journey or whatever it is to feel better?
I would say I'm like a very reflective person. Reflect on like what makes you unhappy during the day. Like what is like your thorn of the day and what's your rose of the day and how can you adjust that? You know, like when I moved to San Diego, I was like, I don't walk anymore. I'm in my car all the time. It's making me really bummed. What's one easy thing I can implement into my life? I started walking every day after work for 30 minutes in my neighborhood.
That's great.
And I was like, I feel better. I would listen to an audiobook and I was like, I've done 2 things. I feel productive, but it's also helpful for my like wellness and my physical being. And so like, I think we have to reflect and think about like, what do I not like? What can I realistically adjust in a way that is like doable? Mm-hmm. And it doesn't have to be big, tremendous things. You don't need to be working like train for a marathon. Like do something that actually makes sense for you in a way that's realistically going to make you happy.
Yeah. That's like our 100-day challenge, 20 minutes every day for 100 days of physical activity.
Yeah.
Just getting out there,
just
doing
20
something.
Minutes.
Yeah. It doesn't have to be an hour, 2 hours.
And if you can go longer, great. But
yeah.
at least just, because if you just go and do it, you'll go. You'll do it longer.
Yeah.
Okay. So where can people follow you, find you?
Are you accepting new
patients?
Yes.
I am accepting new patients always. I am located at the UCSD site in Kearney Mesa.
Okay.
I see patients there almost 5 days a week. I do prenatal care and then general GYN care as well. And then you can always refer to my one season podcast. It's called Gin and Tonic or GYN and Tonic.
Oh my,
So
I love
clever.
that.
I did it with my best friend, Dr. Supraja Rajagopal, who's based at Fenway Health in Boston. It was her idea, and we just wanted to go over topics that are traditionally uncomfortable for people to talk about, like egg freezing, what postpartum is like, and they're just fun topics.
Oh, wonderful.
But yeah.
And then, so if they want to find you, they just find you at UCSD Health, or how does that?
Yeah, you can literally just Google
Okay.
UCSD OBGYN. It'll list all the providers. We all have profiles, and you'll notice that people have different interests.
Yeah, I noticed that on yours, and that's why I was looking specifically for
Yeah.
perimenopause, menopause, and I saw that on yours.
Yeah, you'll see on mine, like, you know, I'm general OBGYN, but I also have an interest in vulvovaginal health, and I do like talking about menopause and different treatment options. But we have many other specialists at our hospital who are also even more qualified to talk about hormone replacement therapy than me, who see many more patients in that topic than I do. So, yeah, you can just find me on there. And so
Wonderful. This has been so great.
Yeah, this
Thank
has been
you.
wonderful.
Yes.
So informative, and also
Very.
really cool to get to know you.
Thank
Yeah.
you.
And I love all my book recommendations
Yeah.
for my
We'll
Kindle.
put that in the notes.
Yeah, definitely.
Yeah.
Show notes for
Yeah.
all of our listeners. And I'm sure this is going to be so helpful to our listeners. I can't tell you how many conversations I have about HRT and perimenopause and menopause and all the things. Even today,
Hysterectomies.
when I walked in, the photographer whose studio this is, we were sharing symptoms just today. I was like, yeah, I don't know, I've been sad lately. And she's like, yeah, you know, I understand. And, you know, it's like, it's so nice to
Yeah.
have an episode like this where not
It's
patients,
validated.
but listeners can get some help.
Yeah.
Or at least find out how to get help.
Yeah,
Yeah.
I agree. Yeah. So
Absolutely.
thank you.
So thank you so much
Thank you for having me.
taking the time out to talk to us. We really appreciate it.
Yeah.
Of course.
Mm-hmm.
Totally.
That's a wrap on this episode of Crazy Stupid Midlife. If you've laughed, nodded, cried, or shouted, "Oh my God, same," at any point, then we're doing our job.
Make sure to subscribe, leave us a review, and share this episode with your favorite midlife soul sister.
And if you're craving more real talk and behind the scenes chaos, come hang out with us on Instagram at Crazy Stupid Midlife, or check out our website at crazystupidmidlife.com.
Until next time, stay bold, stay curious, and remember, midlife isn't a crisis, it's a creative comeback.